So kia ora koutou, ko Jacqui Summers toko ingoa. As Sally mentioned, I'm a manager in the health practice at Deloitte. Formerly worked with Francis Health before they merged with Deloitte on improvement in the hospital space. And up until 6 months ago, was working in commissioning and service improvement in Te Whatu Ora, Waitaha, Canterbury. And very happily joined by Kavi today.
Kia ora koutou. Ko Waikato te awa, te pukikoe, te maunga. Sorry. Ko Tamaki Makoto, no Tamaki Makoto Oho. My name is Kavi. Yes, thanks for the introduction. Yes, I am not a clinician. I'm not a data scientist. I'm just a designer. Who just does happen to have a relationship with geriatrics in the sense that the long-suffering but very proud partner of a geriatric fellow. Marie Puja says hi and be nice to me, please. So today's chat is a little bit different from the more technical side, I guess. As designers, as people trying to make better systems and for the individuals who are experiencing them and the people who are giving care. AI holds a bunch of different opportunities, particularly from the generative AI side, as opposed to machine learning. And that's just about, trying to build connections between sources of information and different users within a system. So that's what we'll focus on a bit today. Sorry, I'm camera.
And we should say we're early in our generative AI journey. So we look forward to curly questions and drawing on our other panel members when we start to talk this through. So just skip on to our next slide. So as we've heard already today, AI is coming and it holds great promise to help solve or address or start to solve, I should say, the myriad of challenges that we're facing here in Aotearoa, but also globally. And efficiency in terms of automation of tasks or the prediction and things that we've already heard a little bit about already in today's sessions is going to be the most immediate gain that we can see from the likes of AI and generative AI, particularly when you consider our labour shortages, the growing acuity, the longer wait lists. And not only is it going to be the most immediate opportunity, but it's also going to be significant. The savings that we're estimating in the US is like 360 billion a year for the next 5 years if we really leverage generative AI. And as a result, a lot of healthcare organizations are starting to lean into this. There's 75% of companies starting to experiment with generative AI or looking how they can scale generative AI. But I think we're at a little bit of a crossroads. While there's lots of interest and while lots of people are going for it, I think it's 41% of the technologists, not even our clinical people, but the technologists are worried about and concerned about the ethics of using AI. And we kind of touched on that today in the discussion already. And I suppose, Kavi, and our challenge to everyone in the room is how can we shape that, right? And by trying to lean into AI now and the possibilities, that's what we think we can help to leverage and shape the future of AI.
Yeah, kia ora, Jacqui. Look, one of the great pleasures of my job is that I get to travel around the country talking to people at all parts of the healthcare system. So from agencies through the people who are receiving care in the farthest reaches of Aotearoa, right? And that's what we do when we're designing services. And I think my experience having talked to so many people and all these different levels is frustration around disconnection. Disconnection between services, between the system and services, between clinicians, and of course, between the patients and all of those. People recently up in Whangarei, someone described their experience as kind of being out to sea and clinging to pieces of debris and having to swim independently from each piece of debris. And that's what it is to navigate the healthcare system for them. So I think, as a designer, one of the cool opportunities for AI is this idea to bring some connectivity between these systems and allow people to translate insights between them. To give, I think, on that, it's just to say that putting people at the center of the system and giving them better tools to advocate for themselves while navigating the system. So that's the kind of stuff that we're really interested in. In terms of like the opportunities, these are all theoretical. People have started working on these all around the world, but as far as we're aware, there's nothing that's really been rolled out that's actually fully fledged and, you know, been deployed yet. But it's interesting and exciting to think about what could happen in the space. Maybe I'll hand over to you, Jacqui.
Yeah, so the first one is similar to what we've already talked about today. We've called it reprioritization, but it's really about freeing up time so people can be more patient facing through the automation of tasks. We've talked about prediction and forecasting to be able to, you know, speed up that process when we go in clinically, so that we can really get to the crux of the issue of what's happening for the person in front of us. And we think by that is where AI is going to go quite quickly and quite significantly. But then what next? And that's where Kavi and I are quite interested in terms of what Kavi's mentioned already, addressing the fragmentation, but also recentering care back to the patients. And I think Kavi had some recent examples that you might wanted to talk to in terms of that reconnection.
Yeah, sure. I mean, again, having a geriatric fellow or a clinician in the family means our dinner time conversation is very stimulating. And I think one of the things we talk about a lot is about the troubles of just handing over data, even between shifts, and keeping the data flows really strong between different teams at the hospital, for example. And so some interesting ideas that have been coming up recently are around how you can use Gen AI to automatically generate summaries to assist in handovers, but also in trying to kind of capture social histories. So you can give people a better chance to kind of essentially meaning that we have a very disconnected system. How can you create the feeling of more continuity of care? And so what's the kinds of information you can share very quickly between fellow clinicians that's going to help someone feel a bit more welcome, a bit more safe when they walk into the room? You can better tailor their care, better personalized care. So that's one of the really interesting opportunities there. Something else was just in terms of, you know, navigating older people's health, is in terms of it can be overwhelming for people and for families and thinking about what their options are in front of them. So when we think about things like advanced care planning, how can you give people more tools to translate their needs into the language of clinicians, into medical speak? So when they do walk in to the hospital, they go meet the geriatrician, the carer, that they can speak the same language. And generative AI is an amazing play there, for example. Yeah. Anything else to add?
We've also recently done some work with Janssen with digital avatars and digital humans, and that's shown that I think it was for self-injection for people with IBD, you know, and having traditional modalities of written information, there was much greater preference for the digital human. So how can we use, multiple modalities across that to really recenter on the human and improve that experience?
And like we said, these are all just theoretical tools, right, at the moment. But there's lots of great stuff that could happen, but there obviously are some real risks and challenges to navigate, as some of the team has pretty referenced today. One of the big ones, and WHO did a report on this recently, and Nature's put out a paper recently on this as well, around ageism and data biases. And of course, we're talking into the room about InterRAI, and so hopefully, you know, InterRAI is working towards helping create better data sets. But essentially, these tools, no matter how smart they are only as good as what you put into them. And so if you're putting biases in, they're going to spit biases out. So so it's thinking about not just the data sets, but also the developers who are working on these things. What are their biases about older people and their expectations of what older people want or don't want? So that's a key risk. The other one is trust and informed consent, right? And yes, it's a utopian and really great idea, awesome idea that, you know, you could have all this data sources coming together to give a person one point of data. But there's real challenges for some people in terms of what data they want to share between agencies, for example. If you're doing something at MSD, do you really want the health to know that, and vice versa? How does that affect what you're entitled to and your insurance premiums? And there's all kinds of implications down the line. So the key question is, do people want this? And if they do want it, which parts of it do they want and what do they not want? Yeah.
And it's kind of like a build on that. So in terms of, yeah, is there trust and consent, but also the algorithms that we're using, are they explainable? Are they simple? Are they open for inspection? So people not only consent to how the data is being used, but they know how the data is being used. And really to do that well, I think we need to have good risk and clinical governance on that. So who is accountable for the final decisions and clinical outcomes? There has to be human touch points along this journey. And like any change process, we need to take our clinicians and our teams along the journey with us. If people are really worried now, will AI take my job? Actually, no, it's more about freeing you up to do the good parts of your job that, make you feel like you've had a satisfactory day. But how do we explain that to people? How do we provide that reassurance? And how do we take the people that we care for along the journey as well? Just got our last slide. Do I hand over to you for this bit?
Yeah, look, I mean, I guess the whole provocation here and why we're here today is to say, lean in. Like, I know we were listening to these amazing two presentations before us, and maybe it can feel a bit overwhelming at times to think about AI and where do you start? But it's our collective responsibility to lean in here, because if we don't, the machine will keep moving without us. And so if we want to guarantee that patient experience and patient outcomes and staff outcomes and experience are prioritized, it's going to take all of us to do that. Advocate for ourselves, but also for older people. As a designer, we want to see older people at the table making these decisions about what these tools do and what purpose they serve in their lives. That's a really important one. As you say, stay fluent. Like it's tricky, but lean in, advocate, and within your organizations to get access to information and to try things out. That's what we're doing at Deloitte at the moment. We're working on lots of proofs of concept, much like our colleagues here today, to try to just play with things. It's only by actually trying these things that you try to figure out what are the problems, what are the frameworks you need, what are the ethics frameworks you need, for example. But you've got to get stuck in to know. Otherwise, we're going to get left behind.
I think Kavi's really summed up what I was keen to get across to, was to make it safe to have a go. So proof of concept testing, even talks like this, we're hoping to help improve fluency. But ChatGPT, you can experiment. But there's a range of other tools out there. So time to lean in now before it kind of, we could miss the boat, I suppose. But we want to lean in to make sure the boat's safe as well. Thank you.
We have got time for Sarah to ask a question.
Thank you. Thank you for that talk. I just wondered if you could say a little bit more about what Deloitte are doing technically, but also consulting patients and clinicians or healthcare professionals, care professionals, whatever.
Yeah, it's exactly this at this point. So we've got a bit of a 5-stage plan, but the number one step is on fluency. So trying to have conversations like this, but also quite targeted workshops with managers, leaders across the healthcare organizations to just bring up everybody's fluency, because it's a scary topic and we want people around the table who are making decisions to be informed. The next stage of that would be to do proof of concept, start testing in safe environments, and then scale and build, deploy from there.
One of the projects that I'm involved in and at the moment is, we're using synthetic data, trying to create safe environments. Like I said, we're trying to do sprint formats. So, okay, let's try solve this in 6 weeks, for example, and prove as quickly as we can, do things work, do people want the outcomes? So yeah, setting up really good frameworks for what are you trying to measure, how are you going to measure it, build something, test it, try again. And that's what we as a team in Deloitte are actually getting stuck into at the moment. Yeah.